Welcome to the ASCO Daily News Podcast. I'm Geraldine Carroll, a reporter for the ASCO Daily News. My guest today is Dr. Pamela Kunz, Associate Professor of Medicine in the Division of Oncology at the Yale School of Medicine, where she also serves as the Director of the Center for Gastrointestinal Cancers. Dr. Kunz will highlight promising advances in metastatic esophageal squamous cell carcinoma and HER2-positive metastatic gastric or GE junction cancer, featured at the 2021 ASCO Annual Meeting. Dr. Kunz has served in a consulting or advisory role for Acrotech Biopharma, Advanced Accelerator Applications, and Ipsen, among other organizations. Her full disclosures and those relating to all episodes of the podcast are available on our transcripts at asco.org/podcasts. Dr. Kunz, it's great to have you on the podcast today.
Thank you so much. My pleasure to be here.
Let's start with the KEYNOTE-811 study. That's abstract 4013. This ongoing global study is assessing whether adding pembrolizumab to standard of care improves efficacy for HER2-positive metastatic gastric or GE junction cancer. There's very promising data in this study. What are your takeaways from KEYNOTE-811?
Thank you. I think this was an exciting interim analysis of this study. And as you said, it's really one of our first assessments of adding pembrolizumab plus trastuzumab in the first-line setting for treatment of HER2-positive metastatic gastric or GE junction cancer. And I think that's why it's really exciting. We don't have an IO or immuno-oncology agent approved in the first-line setting for HER2-positive disease. So I think we are eagerly awaiting the final results. And Dr. Janjigian presented some early efficacy results of this study. So just to review for our audience the design of the study so we know exactly what interim data were presented. This is a study, it's a 2-arm study, randomized 1-to-1 of patients with advanced gastric or GE junction adenocarcinoma, no prior therapy, and are HER2 positive. And patients are randomized to receive pembrolizumab plus trastuzumab and fluoropyrimidine or capecitabine oxaliplatin versus placebo plus trastuzumab and the same chemo backbone. And in this interim analysis, about 260 patients out of the planned total of 692 were presented. And this was a planned analysis that was really based on these 260 participants enrolling for about 8.5 months of follow-up. And the authors presented objective response rate. We do not yet have overall survival or progression-free survival, but the objective response rate was quite promising. So in the pembro-containing arm, there was a 74% objective response rate compared to 51% in the placebo arm. And this absolute difference was about 22%. This was statistically significant. And I think other key take-homes, I know our audience does not have the visuals of the waterfall plot, but suffice it to say that in the pembrolizumab waterfall plot, we had deeper responses. So meaning higher level of objective responses. About 30% of this population had decreases of 80% or more by RECIST criteria. And the duration of response was longer in the pembrolizumab arm compared to the placebo arm, 10.6 months median duration of response compared to 9.5 months in placebo. I think that the adverse events were as one would expect with adding pembrolizumab to this regimen. So I think it's very promising. It did, in fact, lead to accelerated approval of this combination, but we are, of course, awaiting the primary endpoint.
Excellent. Well, let's turn our attention to the CheckMate-648 study. This is late-breaking abstract 4001. This is the first global phase 3 study to evaluate both a chemoimmunotherapy combination and an immunotherapy combination in advanced esophageal squamous cell carcinoma. Can you tell us about potential new treatment options to emerge from this study?
Sure. I think, this study similarly is really important because it's the first immunotherapy in the first line setting for squamous cell carcinoma. We had already nivolumab and pembrolizumab approved in the second line setting, but no IO agent in the first line setting. So this study was a 3-arm study to evaluate, as you'd mentioned before, first line squamous cell carcinoma, this advanced or metastatic. And the arms are as follows. So it was nivolumab plus chemo versus nivolumab plus ipilimumab versus chemotherapy. And the chemotherapy was a fluorouracil plus cisplatin backbone. Over 900 patients were enrolled to this phase 3 study. The randomization was 1:1:1. And statistically, the comparison, the way the study team designed the study was to compare Nivo plus chemo versus chemo and Nivo plus Ipi versus chemo. And so this was, the analysis was conducted in that manner. I think it's also important to note that PD-L1 status was collected and was balanced between the arms, as were other standard baseline characteristics. So when we're looking at the data, I'll first just describe the Nivo plus chemo versus chemo. And perhaps maybe we'll just take a big kind of 30,000 foot view of what these results say. So really the take home is that both Ipi and Nivo and Nivo plus chemo were better than chemotherapy alone. So I think that what we will see is that I'm hopeful these are not FDA approved yet, but I think that in a large phase 3 study, we're hopeful to see these become available for the first line treatment for advanced squamous cell carcinoma. So we saw an improvement in overall survival of Nivo plus chemo versus chemotherapy alone. This was seen in both the PD-L1 greater than or equal to 1% and all patients, regardless of PD-L1 status. And in terms of the overall survival difference, the median OS for Nivo plus chemo was 15.4 months versus 9.1 for chemotherapy alone. This was a hazard ratio of 0.54, so a very clinically significant difference. And we also saw a statistically significant and clinically significant difference for all randomized patients, regardless of their PD-L1 status. So that's overall survival for the Nivo plus chemo. We also saw a benefit in terms of progression-free survival for that same arm, so the Nivo plus chemo arm. And then moving to the Nivo plus Ipi arm, and I think I want to just comment that I think it's really important for our patients to have a chemo-free option. Some of these patients are quite sick. The cytotoxic chemotherapy can have a different set of side effects compared to our immunotherapy agents. And I think it's important to be able to tailor these treatments to the patient that you see in front of you. So some patients may better tolerate cytotoxic chemotherapy, and some may better tolerate IO. So I think that that's important. So this Nivo plus Ipi also showed a statistically significant difference in median overall survival. So the median OS for the Nivo Ipi arm was 13.7 months compared to chemotherapy alone of 9.1 months with a hazard ratio of 0.64. And we also saw a difference for all randomized patients, regardless of their PD-L1 status. So the difference really for both of those arms, both of the IO containing arms was higher for the PD-L1 greater than or equal to 1%, but the benefit was maintained regardless of the PD-L1 status. Similarly, progression-free survival, we saw a benefit compared of Nivo plus Ipi versus chemo alone. So I think that we are hopeful to see an ability to use this for our patients in the first line setting. I think what's really remarkable is that in the last really 3 to 4 months, we have seen an explosion of FDA approvals and phase 3 results for esophageal, GE junction, and gastric cancers in the with IO. And so it's exciting. It's frankly hard to keep track of.
Absolutely. Dr. Kunz, thanks very much for joining us today to highlight these key abstracts in the GI field.
Thank you so much.
Well, before we go, I'd like to tell our listeners about an upcoming episode of the podcast that will feature another interesting discussion with Dr. Kunz. She'll tell us about an interesting session from the ASCO Annual Meeting that looked at ways to dismantle gender disparities in the global oncology workforce. Dr. Kunz will also tell us about a new study on sexual harassment of oncologists. And finally, thank you to our listeners for joining us today. If you enjoyed this episode, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.